the spinal motor neurons and the phrenic nerves. And that is when the cough occurs. So the origins of cough in the respiratory diseases. So it is due to the airway inflammation and production of excessive mucus, or it can be due to a spasm of the bronchial smooth muscles in conditions like bronchial asthma. We know it is due to the spasm of the bronchial smooth muscles, or it can be due to the direct stimulation of the cough receptors. So these are the specific lower respiratory stimuli. It can be the stimuli can be due to excessive secretion, a foreign body, can be either a cold air or dry air, and can be due to allergy also. As I already told, the location of the disease, the nature of the disease and the severity of the cough depends upon the location of origin. As I already told, cough is the hallmark of the airway disease. The maximum number of cough receptors are seen in the airways. And the airway problem which produces the cough, it can be within the lumen, in the wall, or outside the lumen. Now about the pharyngeal cause of cough. So this is the most common cause of cough in our upper respiratory tract infections that we commonly see in our day-to-day practices. And here we have to think, why does an upper respiratory infection produces this much of cough? And this cough is due to multiple factors. It can be either due to an opening of mouth due to a nose block. It can be due to the virus itself, which will destruct the epithelium and exposes the subepithelial receptors, or it can be due to the postnasal drip. Postnasal drip is a very, very important cause of the upper respiratory infection cough. So this is the most common cause of cough that we see in our day-to-day practice. So this picture is really, really important because this is usually kept during the discussions on antibiotic stewardship. So this is the normal timeline of a usual viral fever. Here you can see many of the viral fevers, as well as the viral upper respiratory infection, they present before you with fever, and the height of the fever will be during the first and second day. And when the fever comes down in the third day or the fourth day, the cough starts or it increases. And this is the time when the bystanders become more anxious and they will come to you. And by mistake, what we usually do is that we are forced to start an antibiotic at this juncture, on the third or fourth day. But if you see this picture, you should remember this is just the normal timeline of a viral upper respiratory tract infection, and the cough which develops and increases on the third or fourth day, and it lasts till the 12th to 14th day. And in some cases, it can last up to 21 days. So 12 days or 14 days is a common timeline. So the cough will take at least 2 weeks. So just cough alone after a viral upper respiratory tract infection, we need not have to start an antibiotics. So what if the cough is originating from the laryngeal and tracheal parts? So for example, we have what is called the croup or the acute laryngeal tracheal bronchitis. The cough will be more violent and disturbing, and the usual cause is viral, and the peculiar nature or the sound of the cough, that metallic cough, will give us an idea that is a laryngeal or tracheal. And can a parenchymal disease produce cough? So for a parenchymal disease, the hallmark is not cough, it is breathlessness. So the prototype is either a pneumonia or a bronchiolitis, but we all know that it usually presents more of breathlessness than cough. And here also, cough can be a presentation usually at the latest stage. So even in our day-to-day practice, what we usually see is that we admit a case of pneumonia, and after 4 or 5 days, the child becomes almost normal, and we are about to discharge the patient, and suddenly the mother will tell you he is having cough. So cough in pneumonia becomes worse, or it is not a danger sign. It becomes more at the time during the resolution. About pleural disease, pleural pathology can lead to dry cough at the onset, accompanied by chest pain in the affected side. So A localized chest pain is the whole hallmark of a pleural disease, and it can also present with a dry cough. Interstitial diseases, in this chronic interstitial lung diseases, there will be mild cough, which is gradual in onset, slowly progressive and chronic. And in the chronic ILDs, over the time, the child fails to thrive. What about acute interstitial pneumonias? Acute interstitial pneumonia, the classical example is COVID, where the child presents with acute breathlessness with generalized signs of viral component. There also the cough is not that prominent. Now coming to some definitions. When should a cough be called as chronic? So there are different guidelines which gives different cutoffs. We have the CHEST guidelines, the British Thoracic Society guidelines, the ERS guidelines, and CICADA guidelines. Majority of the guidelines give an arbitrary duration of 4 weeks as a cutoff for between acute and chronic. Except the BTS guidelines, which say a duration more than 8 weeks as a cutoff for this thing. So acute cough is any cough which is less than 4 weeks duration, whereas chronic cough is daily cough lasting more than 4 weeks. And what is recurrent cough? Recurrent cough is when there is repeated frequent episodes of cough with definite symptom-free interval in between. So this is a picture which depicts the presentation of different etiologies of cough. So here you can see 3 types of cough. One is an acute cough with a delayed recovery. This one, acute cough with a delayed recovery. This is what we very commonly see, a viral upper respiratory infection, and following that, a post-infectious bronchitis, which will take around 14 days to 21 days for a relief. So this is a acute cough with delayed recovery. What is this? Recurrent acute cough. So this recurrent acute cough is very typical of hyperreactive airway diseases like bronchial asthma, as well as in allergic rhinitis also we will get. We get a cough which peaks, then comes down, the child becomes very normal. Then again, so recurrent episodes of acute cough is usually seen in bronchial asthma. We should be more worried about the third variety of cough, when a cough is persistent, non-remitting like this. So a case of cough which is relentlessly progressive without any relief in between. So we should be worried more about such type of cough. Now about the progression and timing. Episodic nocturnal cough we get in asthma as well as postnasal drip. And any cough which starts immediately upon lying down or in the supine position is commonly seen in the postnasal drip. Nowadays, it is called as the UACS or the upper airway cough syndrome. A cough which is more common in the early hours of the morning is usually due to asthma, and a gradually worsening cough is seen in conditions like pertussis. Pertussis is coming back nowadays. So even in the vaccination and immunization era, we are getting cases of pertussis. So cough which is coming after feeds and more on the lying down position can be seen in conditions like GERD. Worse in the evening, especially in the school-going kids who are in urban areas, it can be due to pollution. Child coughing after exercise only, it can be due to an exercise-induced asthma or exercise asthma which is exacerbated due to exercise. A cough which is loud, bizarre, but characteristically absent during sleep is what is called as psychogenic cough. We previously used the term psychogenic cough, but nowadays we say it is what is called the habit cough. So these are the different clues by which we can diagnose a cough by the history alone. Some more things. Throat clearing is seen in the postnasal drip. The post-viral cough is dry and irritating. The barking cough is in the laryngitis and the throat. Brassy cough is in the tracheitis. Paroxysmal cough is usually seen in the pertussis, and asthma presents more with nocturnal symptoms. And this wet rattling cough, which is persisting, is very important. We have to rule out any suppurative lung disease like bronchitis and cystic fibrosis. What about investigations in cough? So we should understand an acute cough, which is usually following an upper respiratory infection, doesn't need any investigations if the child is otherwise normal. Suppose this child is very active, playful, is not having fever, is not having breathing difficulty, is otherwise very active. The only symptom is cough alone. There is no need to intervene. There is no need to do any investigations. But a recurrent cough or a chronic cough which lasts more than 4 weeks, we need to do some investigations based upon a detailed history and examination. So what about X-ray? Is it required to do an X-ray in all cases? X-ray may be normal in majority of cases without any findings, but we need to do an X-ray in chronic and recurrent cases of this. So these are some of the findings which may be seen in X-rays. It can be normal in asthma, postnasal drip, aspiration syndromes, in habit cough, all those things, it can be normal. And if there are persisting shadows, we have to think of conditions like tuberculosis, foreign body, congenital anomalies, and focal shadows. It can be due to pneumonia, nodes, tumors, cyst, all these things. So X-ray only based upon a detailed history and examination. If it is suggestive of something, you need to do an X-ray. And these investigations also, these are not to be done routinely, only based upon a detailed history. You can do a sputum examination, especially in places like in our country, in India, being TB being very rampant, we have to do a sputum examination as well as a Mando test and CB-NAT also. And if you're suspecting a suppurative lung disease cases with persisting cough, productive cough for weeks together, we have to do an HRCT to rule out a bronchiectasis. And if the history is suggestive of a foreign body, or if it is suggestive of an airway compression from outside, we have to do a fiber optic bronchoscopy. Aspiration syndromes, we have to do a barium studies, and heart diseases, and all these things only based upon a history. Now coming to the very important thing, in our day-to-day OP, a child is coming with cough. Mother is bringing a child with cough. When should you worry about this cough? So what are the red flags in a case of cough? So any child with cough presenting with feeding difficulty, drooling, choking, you have to think of this. Daily moist cough. This is a very important symptom I already told. It can be seen in conditions like bronchiectasis, cystic fibrosis, primary ciliary dyskinesia. Though they are rare, we have to think about that. And any child who is relentlessly progressing without any relief in between, we have to think about conditions like pertussis and pneumonia and those. Then failure to thrive. In normal case of a child who is otherwise normal won't develop a failure to thrive. So any child who is dating a failure to thrive associated with cough and all, we have to think about conditions like cystic fibrosis. Then neonatal onset. Will a neonate cough? A neonate can get a cough, but it is highly unlikely, and you have to think about some serious diagnosis when the neonate is presenting with severe cough. Hemoptysis is another red flag. Persistent hypoxia, cyanosis, murmurs, all these things you have to look for. Persistent voice changes and sudden onset with choking. It can be due to a foreign body. So these are the red flags when we have to suddenly act, rather wait. So those were the symptoms, and these are some of the signs where the red flags should be thought in mind. So hypoxemia, tachypnea, cardiac murmur, clubbing, altered sensorium, all these things are. Altered sensorium is very important, in particular in this scenario. 3 or 4 weeks back, we had a talk on influenza-related encephalitis. So nowadays we are getting the non-respiratory complications of influenza also. So we have to think about that also. So coming to the management, so a discussion about the cough syrups. The management includes pharmacological and non-pharmacological. So the coming slides will be more about the benefits versus harm of these available cough syrups and whether we should prescribe them or not. So what are the different types of cough syrups? Basically, we have 6 types of cough syrups. We have the expectorants, suppressants, bronchodilators, decongestants, mucolytics, and demulcents. So what are these? We will come one by one. So what are the expectorants? So expectorants, as the name indicates, is used to bring out the sputum to make the child expectorate. So we have different types of expectorants like the sodium and potassium citrate, the iodates of potassium, guaifenesin, this non-modern medicine products like Vasaga, balsam of Tulu, ammonium chloride, all these things are expectorants. But the commonly used expectorant is guaifenesin. In at least 90% of the available cough syrups, the expectorant is guaifenesin. So what is guaifenesin? How does it act? So guaifenesin acts by drawing water into the bronchi. So what it does is that it thins the mucus and lubricates the airway. So how does it help? So it helps by facilitating the removal of mucus by cough. So temporarily it will aggravate the cough. So when you prescribe guaifenesin, you have to tell this point clearly. So you are going to aggravate, a little bit of aggravation will be there because the child will cough more, a little bit more. Another thing is that you have to avoid combinations of antihistamines and these expectorants because the antihistamines dry up the mucus and counteract the expectorants action. So two counteracting drugs together as a combination is totally irrational. So what are the other side effects of guaifenesin? One is dry mouth. So adequate water intake should be advised. Nausea and vomiting also is this thing. So always tell them to take the cough syrup after food. So what is the dose of guaifenesin? It is advised only from the age of 6 years, not below that. But in our day-to-day practice, we commonly see that even in infants and neonates, we prescribe cough syrups which contain expectorants. But as per the guidelines, it is recommended only from the age of 6 years. And for 6 to 12 years of age, it is 100 to 200 milligram Q4 hourly. But even though it is written Q4 hourly, in our day-to-day practice, it is not practical to use it 4 hourly. Even 6th hourly will be very difficult. So what is usually advised is twice a day or even single dose will do. And in more than 12 years, we have to use it in a dose of 200 to 400 milligram. So that is about the expectorant guaifenesin. So only in a wet cough, which is a productive type of cough, you advise this expectorant. This should not be used in a dry cough. Now coming to cough suppressants. So this group of drugs is really when we say antitussive, this is the drug which stops the cough. It will suppress the cough. So it decreases the urge to cough by reducing the cough reflex. Hope you remember the cough reflex arc which was discussed in the beginning. So either the drug can act either in the peripheral cough receptors or it can act centrally. So a cough suppressant is usually useful in a dry, irritating cough that doesn't produce mucus. It minimizes the coughing, but it should not be used in a productive type of or wet type of cough. You should not prescribe a cough suppressant. So we have the different classes of this thing, the opioids as well as its derivatives. We have codeine, folcodeine, and the derivative of opioid, which is called the dextromethorphan, which is the most commonly used antitussive in our practice. So dextromethorphan, it is a opioid derivative, but is not having any analgesic or additive properties. It acts centrally. It is a centrally acting cough suppressant. We have the peripherally acting cough suppressant as well as a centrally acting cough suppressant. Dextromethorphan is a centrally acting cough suppressant. It has got a long duration of action, 8 to 12 hours. So even though the recommendation advises to use it on a basis of BD or TID dosage, what our IAP standard treatment guidelines, which was released recently, what the standard treatment guidelines is recommending to use dextromethorphan as a simple nighttime dose. Remember, it is recommended only above the age of 4 years. So only above 4 years as a single nighttime dose, 0.5 milligram per kg is the recommended. So it has got interactions with this antipsychotics like this MAO inhibitors and SSRI, so it should not be used along with them. So that is about dextromethorphan. Codeine, it is also an opioid derivative, but it has got the side effect of dependency. It is also a centrally acting cough suppressant. It is not freely available also. As far as I know, it is not available for purchase in this for the pediatric population. And if it is really required, I think it is available with the palliative care centers, it will be available. So as far as possible, please do not prescribe codeine. And the adverse effects, we know, vomiting, constipation, urinary retention, respiratory depression is a very, very important adverse effect. So we should not prescribe codeine unnecessarily. Pupillary dilatation also, the dose is 1 milligram per kg per day in 4 divided doses. So previously it was used in very distressing cough in cases of pertussis, but now the guidelines of pertussis is telling not to use any antihistamine because the treatment for pertussis is mainly around using antibiotics, the required antibiotics, not about the cough syrups. Now coming to another important comparatively recent drug, this is a peripherally acting cough suppressant, levodopa-propysin. So this propysin was available for last 20-30 years, but the racemic form, the levo form was found for the last around, I think, around 12 years back, but of late only it became more common. So it is a peripherally acting cough suppressant, which is a non-opioid. And as far as I know, I have used personally in some of the patients who are not responding to in cases of dry cough, not responding to some other medications, it is giving good response. So the dose is in 2 to 12 years, only about 2 years it is advised. 2 to 12 years, it is 1 milligram per kg per orally, PID or BD. And in about 12 years, it is given as a dose of 60 milligram. And it should not be used more than 7 days. So having said all these things about the antitussives or the cough suppressant, should we really prescribe that? We should remember there is a lack of robust evidence about prescribing these cough suppressants in children. And the only drug which can be used, only 2 drugs which can be used is dextromethorphan and levodopa-propysin. So dextromethorphan is that may be warranted in unusual circumstances like severe prolonged cough interfering with feeding or sleeping. But codeine, as I already told, an absolute no. Coming to decongestants. So decongestants are also helpful in relieving cough. It acts by causing vasoconstriction in nasal mucosa and decrease the mucosal edema. So what are the decongestants that we have? We have the phenylephrine, oxymetazoline, silometazoline, and pseudoephedrine. Phenylephrine is a very commonly used cough syrups in majority of these things. It is used as an anti-cold medication also, a combination of an antihistamine with phenylephrine. These majority of these drugs like Viminic, all these things contain phenylephrine. That also is prescribed only above 2 years of age. That is also a common mistake. We are not supposed to use a combination of phenylephrine and antihistamine in less than 2 years. What about phenylpropylamine? It is not at all used now. It has been banned a few years back. So decongestants, they give a temporary relief of nasal congestion. The adverse effects, we should be very careful. Tachycardia, arrhythmias it can produce. So when you are using in less than 2 years, so be extremely careful. As per the guidelines, it is not recommended to be used less than 2 years. So if you are using it off-label, be very, very careful. So arrhythmias, sudden death is all these things can occur if you use it with a higher dose. And prolonged use can cause what is called as the tachyphylaxis. There won't be any response even if you increase the dose after it release. And another dreaded complication is the rebound congestion of the nose, which is called as the rhinitis medicamentosa. So that is about the decongestants. Now coming to antihistamines. This is also a most commonly used or misused drug in cases of cough. So antihistamines, they basically block the histamine activity. So it is basically it is recommended for cases of cough associated with allergic rhinitis. So for allergic rhinitis, as and when needed, antihistamines are extremely useful, but not in other cases. We have the adverse effects includes the drowsiness, dry mouth, dizziness, and all. We have the first generation, which includes the CPM and diphenhydramine. And second generation, we have the cetirizine, levocetirizine, fexofenadine, loratadine, and the latest ones like bilastine. So these are the doses of the different antihistamines available. I'm not going to the details of that, but you should remember majority of the antihistamines are prescribed as a once daily dosage, not as BD. It is usually prescribed as among these, levocetirizine and cetirizine are the most commonly used, also fexofenadine. And chlorpheniramine and diphenhydramine are the first generation ones. Now coming to another group of this thing, what is called as the mucolytics. So what is mucolytics? So as the name indicates, it lyses the mucus. And among these, we have the different drugs like bromhexine, ambroxol, acetylcysteine, carbocysteine, but the most commonly available one is ambroxol. So what is the mechanism of action of mucolytics? It increases the production of serous mucus in the respiratory tract. So basically, it makes the phlegm thicker and less sticky. So it is also a drug which should not be used routinely in our day-to-day practice. So it is very commonly used in common cold, but it is not recommended to be used in common cold. It is recommended to be used in long-standing conditions like bronchitis, cystic fibrosis, and all. Only in conditions with very thick mucus and LRTAs, it is recommended. Now coming to about the bronchodilators. So are they useful? Salbutamol and levosalbutamols. So this is the most commonly used drugs nowadays. Even all the parents and bystanders, they know the name salbutamol. They have started telling more. It has become a more common name, even more than the paracetamol. So every parent knows salbutamol, levosalbutamol. But should it be prescribed in all cases? It can be safely prescribed in different cases of cough, but response to salbutamol will be there only if there is an associated wheeze. So it is more useful in cases associated with wheeze like bronchiolitis, asthma, and the wheeze associated lower respiratory infections. And in that also, inhaled drugs are preferred. But in our day-to-day practice, we are using syrup salbutamol, syrup aspirin, and all this thing we are prescribing. But ideally, we have to prescribe inhaled drugs. And if it is a case of asthma, we have to, this is an opportunity to start the inhaled medications. You can prescribe bronchodilators. So dose is 0.15 mg per kg per dose if you are giving it by nebulization. Now coming to combination cough syrups. So in India, we have only a few drugs which are available standalone, like salbutamol. But the other groups of these cough suppressants and expectorants, we are very difficult to purchase it as standalone. Will be available as combinations. The majority of expectorants that we have in our pharmacies will be a combination of a bronchodilator and ambroxol or bromhexine and guaifenesin. So it is a combination of a mucolytic and an expectorant and a bronchodilator. The majority of expectorants will be like this. And majority of the suppressants will be a combination of dextromethorphan with phenylephrine. And the decongestants will be a combination of antihistamines and decongestants. So these are the different combination cough syrups available. But as far as possible, we have to use the standalone drugs like salbutamol if it is available, if it is effective. But unfortunately for us, these drugs are not available separately, so we have to use it. But we should always make sure that we are sticking to the correct dose of this, correct recommended dose of these drugs. This combination as such is not satisfactory because there will be differences in time course of action of the components and liability for indiscriminate use also. And the next sentence is very important. The fixed dose combinations of a centrally acting antitussive with a bronchodilator or with a antihistamine have been banned in India for so many years, but still they are marketed under different names. The combinations of these dextromethorphan with antihistamines and all, this all the three drugs together is actually ideally, this is actually banned in India, but still it is available, unfortunately. So this is a very, very important question. What is the efficacy of the antitussive or the counter antitussive for children with a viral upper respiratory infection? So studies have proven that these antitussives are no more effective than placebo for reducing cough from viral URS. So it should not be used in children less than 6 years because we do not have adequate safety data in this age group. So OTC these over-the-counter antitussives are not recommended below the age of 6 years. Now about steroids. Steroids in acute cough. So in acute cough, if it is due to asthma, steroids will be effective. So we can use prednisolone or hydrocortisone in a for very short case. If it is a case of asthma or if there is a bronchoconstriction. Otherwise, there is no evidence of efficacy in acute cough. In viral URTAs, it is not recommended. Even though GINA is recommending in less than 5 years for a short case, a short course of inhaled steroids, recommending for this non-frequent cases of upper respiratory infections. What is the role of nebulization? Role of nebulization. Nebulization is a thing which is very commonly demanded by the parents. Parents will always ask for nebulization. In our case, we say, but only if the diagnosis is asthma or croup, nebulization will be effective. Otherwise, it won't be effective in other etiologies of cough. So this is another important drug, honey. You may ask whether this is a drug or it is a natural product. But we have enough evidence now that honey is very, very effective as a demulcent. It is a demulcent. So how does it act? It acts by creating a coating over the peripheral receptors. It forms a coating over the cough receptors peripherally. And also it increases the saliva and as well as the swallowing. And in some way it will decrease the cough. And there is one study which I have quoted here. It has specifically found that honey was slightly superior to placebo or not treatment, or even better than an antihistamine like diphenhydramine, and was equally effective to dextromethorphan in reducing the frequency of cough. So it can be prescribed. There is no standard guideline about the dosage and all. What I usually do in my practice is that only above 1 year it is recommended, not below 1 year. There is a risk of botulism below the age of 1 year. So only above the age of 1 year, you can use as a half teaspoon or 1 teaspoon, that is 2.5 ml or 5 ml, depending upon the age of the child. Now, finally, coming to the role of excipients in cough syrups. What are the excipients? So, any cough syrup, you take a combination cough syrup, you take, there will be a lot of other components also. So, there will be the active ingredients. For example, if you're taking a expectorant, there will be an expectorant, there will be a bronchodilator. And along with that, there will be some other products also, like sweeteners, thickeners, flavors, colors, antimicrobials, buffers. And some of these components may be having some role in controlling the cough, like sweeteners and thickeners have got some role. There is one paper which I have quoted there. It has, this study have found that the inclusion of the sweeteners and thickeners may in some way help to decrease the intensity of the cough. Now coming to the last part of my talk, counseling of parents of a child with acute cough. So we should take care to counsel the parent. That is, the parent of a child who is having a very severe cough, they will be immensely tense. They will be worried. They won't be getting a proper sleep. So in all ways, they will be the father, the mother, grandmother, everybody will be coming very anxiously. So you have to counsel the parents about the natural history of the cough. You can use that picture which I showed in the beginning part of my talk. an upper respiratory infection, what is the natural history, when will a cough start, when will it end. And educating the parents properly will allay the anxiety of the parents, patient, and the doctor and avoid polytherapy. And you always tell them about the red flags. I already demonstrated that red flags. You tell the parents to bring back the child only if there is red flags like fast breathing, difficulty in breathing, not able to drink or feed, recurrent vomiting, or otherwise the child, if he is looking very sick, then only they need to come back. So counseling is very important, but it requires time. That is that thing that we do not have. So finally, the take-home messages from this talk is evolution of origin of acute cough is important for therapeutic decision making. And for an acute cough, we do not need any investigations. The only exception is a foreign body where we have to do a fiber optic bronchoscopy, which is both diagnostic as well as therapeutic. The management is etiology driven and mostly to afford symptomatic relief. Home remedies are overhyped. You should not rely upon them, but still, if it is non-dangerous in some way or other, you can please do not discourage the parents about the home remedy. Some parent will ask you, is it okay to apply Vicks or Vaporub? It won't cause much harm, so you can advise them. So home remedies, if efficient and beneficial for the individual patient, if it is not dangerous in any way, you can recommend them. Combination cough syrups have got no beneficial role, but in our scenario, we do not have other options like standalone drugs are mostly not available, so we have to depend upon them. So choose those cough syrups with less number of combination rather than four. There are some drugs which have sub combinations which have 4 drugs: an antihistamine, bronchodilator, cough suppressant, and a expectorant. So that should not be used. And prescription of antibiotics only in bacterial etiologies is very difficult. It's very easy to say, but very difficult to convince our patients on a day-to-day basis. And the last slide, parent counseling is the most important component of management of acute cough. So that is about this presentation. If you have any doubts, we can discuss.
Sir, we have a few questions in the chat.
Okay, I will take.
Thank you, Dr. KM, for the wonderful talk. And very happy that we have got a wonderful attendance too. Maybe it had reached more than 130 at times. And you have made it so simple for our members to understand. Over to members for their doubts. You can type your doubts in the chat box and Dr. KRISHNAMOHAN will be answering it.
Thank you, Devin sir. Kindly tell the dosage. Which age group can we give mixture expectorant syrup? So that is what I told. Expectorants are drugs which will try to bring out the sputum from the respiratory tract. So until and unless the child is having a good effort of cough, so it is not recommended below 4 years. That even any drug is not recommended. None of these expectorants are recommended below the age of 6 years. I mean 6 years. So next question is.
The video post, can you post now? See, actually we have a YouTube channel, KGMI Calicut. So we'll be posting this session there.
Tomorrow. Maybe tomorrow.
Okay.
For acute onset spasmodic cough, most likely due to bronchospasm that occurs in bouts, may not associate with positive symptoms, should bronchodilators be considered. So in such cases of the bronchoconstriction, if you are suspecting asthma or a bronchiolitis, you can try, definitely try a bronchodilator. Children less than 2 years, which cough syrup is safe to give? So there is no combination cough syrup which can be given. Ideally, there is no recommendation for that, but we can try salbutamol if the cough is due to a bronchospasm, like due to bronchial asthma, or you have an allergic etiology, you can use this thing. And antihistamines also, if the cough is due to an upper respiratory tract infection, like due to a common cold, you can, for a few days, you can use antihistamines. Cetirizine you can use from the age group of 6 months onwards. Terbutaline cough syrup is recommended in children. Yes, it is recommended. It is the exact age group from it is recommended. I don't remember, but it is used in children. That should be prescribed to infants. What should be prescribed to infants? We can find a number of drops containing phenylephrine and CPM. There are different drops available, but as far as possible, please do not use them. As I already mentioned, many of these antidepressives are having arrhythmias as a complications. So it is always better not to use them. Is steam inhalation effective? What is its mechanism? Steam inhalation basically causes a hydration, and it may give a temporary relief of symptoms, but it is not recommended as of now because of the risk of causing burns. The steam burns, it is not given as a recommendation. But in our day-to-day practice, we usually, for a grown-up child who is able to do it safely, we recommend steam inhalation, but it is not recommended. What is the difference between levofloxacin and levodopa? Actually, I don't know this levofloxacin. Sorry, somebody else knows. I think it is levofloxacin is a centrally acting antidepressant. Levodopa is a peripherally active. Bacterial etiology, if fever persists, yellow-colored sputum is suggestive of bacteria. Yellow-colored sputum, especially the nasal discharge, which is yellow color, is not at all suggestive of a bacterial infection. The symptoms, the severity of the symptoms are more important, and you have to think of differential diagnosis like sinusitis if the symptoms are long-lasting. That is, any respiratory symptom like cough and nasal discharge lasting more than 10 days, we have to think of etiologies like sinusitis. That simply that yellow color itself is not a diagnostic feature. Is there a role of hypernebulization, 3% nebulization in cold and cough? In cold and cough, there is no definite role, but if the child is having a bronchiolitis, it can be used. Combination of cetirizine and ambroxol, is it good? You can use cetirizine. Depends the question. The answer to that question depends on for what indication you are using it. If it is for common cold, ideally we do not need a ambroxol. Only cetirizine is enough. Can we use CPM with phenylephrine combination in children less than 2 years? That is what I told. As per this recommended, it is not recommended below 2 years, but above 2 years you can use. I think the questions are over. Dinesh?
Sir, any more questions? See, you can ask. This is the time. Already
somebody has asked, had 14-year-old female with complaint of eye ache, headache, and facial pain from the last 7 days, had cold and cough for 2 to 3 days, resolved 4 days back. On examination, had sinus, tenderness. From the diagnosis made was sinusitis. So sinusitis, if you have made the diagnosis, you have to give antibiotics, and the duration is more important. If you are using amoxiclav, you have to give it for 10 to 14 days. Long duration of treatment is required. Role of antibiotic in cough, very simple answer. On the etiology of the cough is due to a bacterial infection, you can use an antibiotic.
Sir, there's a question. Hello, sir, am I audible?
Yes, please.
So the question I just posted about sinusitis, the patient was not febrile, like right from the start, but just she had this ocular pain and this facial tenderness. So in that case too, we have to advise antibiotics.
Actually, in sinusitis in children, that facial pain is not a important sign of symptom. More important is the persisting cough and the thickness of the nasal discharge after 10 years. So if you feel that it is a case of sinusitis and the patient is not responding to your other treatments, you can try a course of antibiotics. Or you can do an ENT evaluation also. You can take X-ray and see the sinuses.
Sir, as of now, I started her on this N-acetylcysteine and this chlorpheniramine phenylephrine along with this low dosage of steroids so that I could be wrong.
Okay. I'm not sure. I'm not sure about N-acetylcysteine in a case of sinusitis. As far as I know, N-acetylcysteine is not routinely used in sinusitis. We use them in cystic fibrosis and all. So I'm not sure about that.
Thank you,
Maybe
sir.
antibiotics will be involved. Somebody has asked if CPM and phenylephrine is not recommended below 2 years, then what to do for running nose and nasal block in that age group? We can use an antihistamine alone, like cetirizine, and also we can use the nasal drops like the saline nasal drops. And for a short course, we can use the nasal decongestants like silometazolone. But when we are using silometazolone, be extremely careful to prescribe the pediatric dosage. So all these drugs are having the adult variations as well as the pediatric. So specifically write for the pediatric drops of silometazolone.
Sir, what is your opinion regarding use of Montelukast?
Montelukast in allergic rhinitis. In allergic rhinitis, it is effective. Other causes of cough, it is not effective. In allergic rhinitis, along with levocetirizine, Montelukast can be used. Also in asthma, also as an inferior option to an inhaled corticosteroid. In asthma, if the symptoms like cough are there, you have to start inhaled corticosteroid. If the patient is not willing to start an inhaled corticosteroid, as a second line option, you can, as an inferior option only, you can think about Montelukast. In other causes of cough, it is not having any role.
For a child aged 15 days to 1 month, presenting with rhinorrhea and cough, what do you suggest?
For a child who is at this age group, say he is a
15
neonate.
days to 1 month.
He is a neonate. A neonate presenting with this symptom is very, very unlikely. And there is no antihistamine that you can prescribe at this age. Only thing is that you can, if there is a nasal block, you can use a saline nasal drops. You have to investigate further to find out the cause. It is very unlikely to get these symptoms at this age group. But there is no antihistamine that you can safely prescribe at this age group.
For running nose, rhinorrhea.
Running nose. That is what I told. You cannot use any antihistamine. If it is a infectious rhinitis, it will even without any treatment, he will respond. He will be okay in another 2 to 3 days. Then I should be worried about that.
For this running nose, can you give saline nasal drops?
Yeah, because
Oxymetazoline.
not oxymetazoline. In a newborn, you can use normal saline drops. This not only for this thing. These patients with common cold will be having an irritation of the nasal irritation, itching. So the normal saline nasal drops will definitely decrease those irritation. So that will be useful.
So you can just leave them. You can leave them alone. Like,
yes.
Yeah. Thanks a lot. Thank you.
So what's the role of ICS in post-viral cough? Any role?
So if you are considering asthma, the most common trigger for an acute attack of asthma is a viral infection. So if it is a case of asthma or a hyperreactive airway disease, which is developing after a trigger of a viral infection, then definitely you can use an inhaled corticosteroid. Not in all cases of post-viral cough. If you are getting a wheeze and if you are suspecting an underlying hyperreactive airway disease, then definitely you can use inhaled corticosteroid.
Sir, another question in chat box: can nebulizer be used without supplemental oxygen in clinic OP?
Ideally, as per the recommendation from the asthma training module of IAP and the national guidelines and all nebulization should only be carried out in the presence of oxygen, with the oxygen, especially in the younger age groups, especially the infants and all, because there is a chance of that ventilation perfusion mismatch, which will lead to a worsening of the hypoxemia. So as far as possible, always try to use oxygen along with salbutamol when you are giving nebulization. But personally, I would say you even do not recommend home nebulization. You say a big no to home nebulization. Nebulization should be done only in clinics or in a hospital setup. In home, you should not use nebulization. Instead, you can use the MDI with spacer, or metered dose inhaler with spacer, you can try.
Another chat is family history of atopy present with a child suspected to having cough variant asthma. Can we give deflazacort?
So what is cough variant asthma? That is a very important point which I forgot to mention. So cough variant asthma is a condition which is considered as a precursor of asthma. So these children will be having some symptoms of asthma. The only symptom in a cough variant asthma is cough. He won't be having a wheeze, he won't be having breathing difficulty, but the child is presenting with cough alone. So the latest recommendation regarding this is that cough variant asthma is first and foremost point, it is very, very rare. It is a overhyped diagnosis. It is not a commonly seen condition. Asthma presenting as cough alone is extremely rare. Asthma without wheeze and bronchoconstriction, all other breathing difficulty, only with cough is extremely rare. So really use, having said this, if you have diagnosed a case, you are definite that the diagnosis is cough variant asthma, then you can use, manage him just like you manage a case of asthma. Like a mild case of asthma, how you manage. So you can use inhaled corticosteroid in cough variant asthma. But you should remember the point which I told, is a very rare entity. But unfortunately, that diagnosis is very commonly made. But asthma presenting as cough alone is very rare.
Sir, I have a question.
Yes.
Sir, actually, I have seen a lot of patients that is coming with post upper respiratory tract cough, which is persisting, even adults. And I have seen that most of the patients responds to steroids. So it's not, no, patients doesn't have wheeze and anything, just irritating persisting cough. Yeah.
Patient will respond definitely, but is it indicated or not? Because after an upper respiratory infection, it's quite physiological to detect cough for 10 to 14 days. So
Okay,
being a steroid is an anti-inflammatory drug. If you give an strong anti-inflammatory drug, definitely the cough may decrease. But is it indicated or not is the question. Another question in the chat box is about what about Montelukast and cetirizine. So ideally, you are not supposed to use a combination of Montelukast and cetirizine. But unfortunately, again, all the drugs which are available, majority of the drugs are coming in combination. It's the Telecastel or Monterel, all of them are coming as combination. But it is a highly irrational combination. If you are using Montelukast, if you are using levocetirizine, use them separately because it is an irrational combination. One thing is that this Montelukast is an alkaline drug and levocetirizine is acidic. You are not supposed to combine them. The dosage, how frequently you give them also, levocetirizine you are giving OD, Montelukast BD. So everything is different. So you are not supposed to combine them. So as far as possible, use them separately, Montelukast and levocetirizine, not as combination.
Sir, even if you use steroids, what is actually, if the patient has wheeze and all, if you use steroids, which one is the safer, sir? Is Visalon or is it deflazacort? Like that?
No. Steroids, if you are using for cough, so you go for inhaled corticosteroid. So inhaled form is more safer, and inhaled corticosteroid, the most recommended one is budesonide. So you can use budesonide.
Okay, thank you.
Chat box, there's one more question. Can adenoiditis be the sole reason of predominant chronic cough with no nasal symptoms?
Without nasal symptoms, it is unlikely. With persistent nasal discharge, severe headache, fever, and persisting fever and all, persisting more than 10 days, we can think about sinusitis and adenosinusitis.
Sir, another one is duration of Montelukast. How long can we give Montelukast?
How long you can use Montelukast? There is no definite clear-cut guidance recommendation from anywhere. But what I do in my personal practice is start it and continue for 3 months, depending upon the response to the treatment. There is no definite cutoff like.
Then another question is between mesh nebulizer and ultrasonic.
These are advances in the technology used in nebulization. I do not have first-hand experience with the type of nebulizers. I am using only that conventional nebulizer.
Is there a role of budesonide nebulization in acute attack of asthma?
Budesonide nebulization in acute attack of asthma, yes, and as per the latest DINA guidelines 2022 onwards, they are telling that it can be used, but at a higher dose, not in micrograms. The dose is, I think, 0.5 milligram every 20 minutes. You can use it, but previously they told that in acute asthma attacks, budesonide is not effective, but the latest Dina is telling that you can use that in acute attacks.
The last one, the chat box, mucolytics in less than 6 months, is it rational? I think
Mucolytics in less than, depends upon the indication. As I already told, indications are different. If you are using in cases of cystic fibrosis and some the suppuratory lung diseases, it is okay. Otherwise, if you are using it in a common cold, it is not recommended. The next question I have already answered. 3% nebulization can be used in bronchiolitis.
I think we have almost answered all the questions.
Last question, what should be given for dry hacking cough in children below 6 years? The only drug which is recommended, 2 drugs which you can use is that one is dextromethorphan, which you can use above 4 years of age. 4 years of age, you can use dextromethorphan. And you can use honey. Honey is very, very effective. You can use honey also.